So shoulder range of motion sequence starts with flexion and abduction. Whilst they go through those movements, I'm looking specifically for the dissociation between the midline, mid-axillary line, and their humeral, the midline of their humerus. And I measure abduction in the front, and I measure flexion on the side. Additionally with that, you'll get better at identifying premature scapular elevation or other compensatory movements. We had a gentleman recently that he demonstrated that, oh yeah, when I do this, it feels better, or it's painful here. But immediately upon doing so, just having seen people raise their shoulders and being keen to like what their scapula does, it immediately told me they had no dissociation between humeral head or humerus and scapula. It all kind of moved as one. So I capture this, and then for the shoulder, I prioritize the rotational capacity of the shoulder much more than the linear movements, right? So linear being extension, flexion, and abduction, because the ball has to be able to rotate very well in the socket in order for this to go well. So when people do wall walks, pulleys, what you name it, those are okay to a certain extent, but they will eventually plateau and people won't be able to reach this cone of space. So then I lie the person flat and I go through the same sequence, sometimes selectively, but barring full discretion of, 30 minutes or session or so, I'll be able to get through both arms in full. So I'll have you go and lie down on your back. So the positioning of the patient matters, so they're going to be on their back, their knees are going to be bent, feet are going to be flat. That allows their torso to lie flat on the table. And then they're going to go into supination, and if we were going to measure your right arm, you'll be about 4 to 6 inches off the side of your torso, which looks fine, and then you're going to we'll recruit your left arm to passively look at your external. I don't do it in standing because there's just too many degrees of freedom. Once the person hits like 45 degrees, I encourage them to kind of come up and over so you have a better line of force. Once they get to their end range, so the elbow will consistently want to drift, so just sort out your back just a little bit. Full breath in, full breath out, so they breathe in, they breathe out. The phone goes on the corner, or the corner of the phone goes right at the styloid, as close to the bony prominence as possible, and I'll take my measurement. I then drop golf club, so they go into and self-impose the external rotation. I always do the internal. So still in this position, I'm going to come in, I'm going to gently, so with my thenar eminence, come over the coracoid process. You don't want to pin the shoulder because you will feel like as the bicipital groove goes into internal rotation, you'll feel a clunk at times. It's not pleasant, but yeah. So then I'm going to stabilize. You're actually limited, right? So notice how I can't hit you there. It doesn't feel comfortable, or you're okay.
It's where your hand up there is.
Okay. So if I change that,
Yeah.
but if I push, then it goes like that, right? So
Gotcha.
same thing. I go there. Still corner of the phone on the styloid. Get my internal rotation. We then move up into the 90-90 position, so you scooch that way. Again, instead of impose, people will relax a little bit better when they're in control. So they go into like the thumb pointing back. You drop back as far as you can. The thickness of the towel is proportionate to the thickness of the torso. And that looks really good. So you drop them back, look at their full external rotation. Big breath in, big breath out, full exhale, rib cage comes down, so you take that out of it. Her forearm angle changes by a couple degrees. And that's my external. Internal rotation. So we talked about the Reinhold article, a couple of, I think it's Reinhold and Wilkin Davies, they wrote a paper about the different ways to stabilize. So in their paper, they talked about the C grip. I like to not use a C grip. I use just the palm to stabilize, the point of the C grip is to stabilize the coracoid. And then I also, with this one, I find it more, go ahead and switch towards me, more effective to use my thigh. Oftentimes I have to adjust the height of the table accordingly. And then come here, internally rotate. Internal rotation is limited, sorry for the pressure on the wrist, but I'm meticulous about keeping them in the supinated position versus this, which you can kind of feel the shift at your shoulder, right? Yeah. And it pre-tensions the tissue, right? So this is going to be coupled, this pre-tensions the tissue in the back of the shoulder like that. And then I'll take that angle. And then I'll do the aggregate, external versus internal, as my total arc of motion.
90.
Yep. Still on the last one I do in supine would be my crossbody. So the crossbody is going to be in this position. We'll recruit your left arm to grasp at the wrist. I'm going to come in, and I'm not going to pin your shoulder blade down to the table. I'm going to pin it like into you. And I think one of the mistakes that people make is that they start the patient already into the motion, bring it out so that you actually get my hand on the shoulder blade on the corner, and then I'm also going to prevent the humerus from rising. As people go across, they drop. They come into this position. You need to kind of keep it at that same plane of movement. So elbow at the height of the shoulder, and then go ahead and go across. It's a lot of pressure on the scap. Alright. So as far as you can. Good. Bring the elbow up just a little bit higher. There it is. And that's pretty much the end range. So nope, don't come out of it. Freeze that. So I take my top hand off, I stabilize, the thumb comes here, I go right onto the olecranon, and then we get our angle. For this one, you definitely want, usually you want the olecranon to be able to cross the manubrium with the stabilization. So the pattern that we're seeing is that there's limited internal rotation, limitation here, and limited cross body. All share a comparable structure of posterior tightness. So that, and then I'll do the same sequence other side. For the moment, we will bypass the other arm, and I'll have you up into sitting. You can actually come off the table if you don't mind. So I'm just going to move it a little bit. So then I use the end of the table. To measure internal and external rotation in the flex position. So sticking with our clustering of the different motions. I thought that we could go in, we could zoom in, but we can't. Okay. So it would be like this. So external rotation, height of elbow is height of shoulder. So it's in a vertical torso or spine. They'd be like this. Palms facing one another, and you go external. Typically people will do something like this, and they will also drift out. Let's see what that looks like. So your external rotation and all the other positions has been really good. We would expect, if we're thinking through our numbers and our patterning, yeah, I would expect 45 degrees or more here. And 51. Internal rotation in this position. We'll trade once more. I call it a modified sleeper. So people typically go aggressive with their sleeper. So I'll turn this way so you can see it properly in the video. So their shoulder's going to want to be here, and it's going to want to be protracted. So I start them in a vertical arm. They come in, they drop shoulder, and then they drop into internal rotation. With their other hand, they are allowed to gently grasp the arm, but not really crank on it. So typically people will go like this, and they're like, got much range, but it's really not what we're looking for. You want to bring them up, pack the shoulders so they rotate towards it, pre-tension the back of my shirt, as you can see, and then they gently set into their internal. And they'll feel like a crescent, deep-seated stretch here. You don't want them to feel like pinchy in the front. Alright, your turn.
Oh my gosh, sorry.
It's okay.
Is it getting here?
Yep.
This way.
Yeah, so you're gonna be like 45 degrees relative to the table.
And then I
Yep.
push it towards it.
Yep. And then we rotate more, and then we talked about packing the shoulder, as I called it. Yep. So it's not just down; it's like back. There you go. Then while I'm facing you, I come in. I like pin the humeral head, and then you slowly work into internal. It's rising. It's threatening to rise. Yeah, and then that's it. Yeah, there's room for improvement there. So typically I like to see people at parallel or below. We're obviously not there. So I document this as minus 25. Right, so this is 0, this would be positive, this would be minus by convention.
Got it. Okay.
Right, so
Yeah,
like,
yeah.
yeah.
Understand.
So if they had like, for instance, I had a guy the other day, like minus 24, and they had 18 on the other side, so it was like a 42-degree difference. So that's my standard. My bonus ranges of motion are overhead. So I'll show you. So when people get really good and they get to the end range of the end of their rehab or the end range of the motion, you'll see a couple of things. They will either side bend, they'll either bend their elbow, or they'll just go straight and then they won't get any further. You'll also see it where they go like this. They go into a flexion drift. That tells us that they can't access this range of motion. That likely means that as they take up some slack of their capsule, they run out of room for their rotation. To restore that, right? I've had patients come to me after seeing physicians or otherwise, and they're doing something funny overhead, or they're pulling on a band and trying to yank it and distract it. It's more efficient and more therapeutic to actually go after the rotation overhead. So instead of just stopping at 90, we flex to 140, and then we look at the external or internal rotation there. So internal rotation is kind of a son of a gun to measure in that overhead position. So I haven't prioritized that, but I will look at people's external rotation. So they come here, they roll back, I measure with the goni, again similar to what I did in standing, mid-axillary line to the humerus, and then we look at how much external rotation someone has. So you're way past it, so you can come forward a little bit. Keep going. Boom. There's your 140. Nice job. And then you're going to go elbows bend, and you're going to externally rotate. And you have plenty of it. Yeah, but mostly, a lot of people will be more restricted there than you. That's pretty exceptional. But we've agreed, or the pattern has been all the way along that internal rotation is the problem rather than external. We would need to look at to say whether we would actually work on your internal rotation range of motion would be determined by your total arc of motion.
Yes.
So if your total arc was 160 or better, and or comparable to the other side within 10 degrees, I wouldn't go cranking on it. But my suspicion is that it could be better.
Yeah.
But your overhead, I'm sure your overhead is fine, and it is, because you have the adequate external rotation. Yeah. And then hand behind back, if again, it's not the first thing I go to, right? I don't use it as a measure. I measure the elements of that. So the elements of that are elbow extension, which we didn't measure because I don't prioritize it. I often find that by working and improving all the others, extension tends to take care of itself without actively working.
Elbow extension?
Shoulder extension.
Okay.
Yeah, but in that case, I would allow someone, either I do it on the table prone or I do it up against the wall, and then they'll be like this or even like that. And you don't want to be fooled about them winging off to the side. It's got to be like a very pure extension. And you're looking for 50 degrees. So ranges of motion around the shoulder are somewhat predictable. Here I'm looking for 90. Here I'm looking for 70, or until they're or I can just push into them, push into their belly fully without any limitations. When we're looking here, right, 90 and or 70, but you're looking for a total arc of 160 is what matters most. Here, I don't have a good total arc for you, but typically what I see is like 40 this way and maybe like 20 below parallel, right? So if you added that up, that would be like 130 plus 20, so it's like 150 approximately. And then overhead, I don't look at internal rotation really. I look at the 140. I will train internal rotation overhead as a means of getting better coupling and making sure that the shoulder is really stable there. But rarely do I see people being internal rotation limited overhead. So that sequence will drive, like taking that tells me exactly where I need to drive my interventions or focus my interventions. And that's separate from what is going to be the primary assessment to identify the tissue pain source. This is more your impairment based.